Welcome to the Vet and Crit Academy, where we discuss veterinary emergency and critical care and science-based tools for veterinary professionals. All right, hello everyone. We're going to talk about parenteral potassium supplementation. So before we start talking about specific calculations and how to supplement potassium IV, I want to make sure we're on the same page in terms of the formulations that we're going to be using to supplement potassium. So on this slide, you will see two examples of most common IV formulations of potassium. Is potassium chloride, KCl, with typical concentration of 2 mq per ml, and potassium phosphate, also known as KPhos, with potassium and phosphate in it. These two formulations are most common in the United States. If you're practicing in another country, I'm going to give you the math that you can use no matter what type of potassium product you're utilizing. But specifically in this module, I'm going to give examples of products that we use here in the United States. As you can see on this slide, besides the concentration of potassium in every ml of these products, you will see the osmolality. We will talk about what osmolality is, but for now, just be aware that KCl 2 mq per ml will have osmolality of 4,000 millismol per kilogram, and KPhos will have osmolality of 5,840 millismoles per kilogram. So what is plasma osmolality? So by definition, osmolality is the number of particles per kilogram, and usually is measured in milliosmol per kilogram. Osmolarity is the number of particles per liter and measured in millismoles per liter. The good news is that 1 liter of any biologic fluid equals to 1 kilogram. So in reality, osmolality and osmolarity are the same in veterinary medicine and human medicine. So you should not worry too much about differentiating between the two. So the higher the osmolarity, the more concentrated the solution is, and the less the osmolality, the less concentrated the solution is. Why do we care about the osmolality? Why do we even talk about it in this module? And that's because certain osmolality could be safe or unsafe for peripheral versus central IV administration. In general, when you read textbooks on parenteral nutrition, they always recommend not to exceed osmolality of 600 millismoles per kilogram for peripheral administration. So you have to dilute your solution to the osmolality less than 600 in order to make it safer. Otherwise, this high osmolality may cause thrombophlebitis or inflammation of the vein due to irritation. So now if you apply this information to KCl 2 mq per ml, you actually have to dilute it to the dilution of 1:7 in order to bring down the osmolality to less than 600. Which will be equal to about 280 mqs per liter. Now, that being said, in human guidelines, they typically recommend not to exceed KCl concentration in terms of mq per liter 60 to 80 when you give it through the peripheral route, which will be equal to about osmolality of 120 to 150. So they want to be on the safe side, and that's what you can find in the literature. Now, when you're giving KCl by the central vein, by central line, you can actually exceed this osmolality of 600 millismoles per kilogram because these vessels are large and it's much less likely going to cause any irritation at that level. The only concern would be if you're using the central line where the tip of the line is located very close to the heart. We don't know how much harm you're going to create by delivering this highly concentrated potassium solution directly to the heart muscle. What if there are going to be complications and arrhythmias related to that? We don't have a lot of research, especially in veterinary medicine, but there are a couple of human papers where they directly looked at that situation. So in this Hutkins et al. 2020 paper, they use a solution with KCl concentration of 200 mqs per liter and administer it to people via the central line, the final osmolality of this solution was 430, which is pretty high, and none of the patients had any issues with that. So in theory, you may give such a high concentration of potassium directly to the heart with no issues, but just keep in mind that there's a lack of research and you should be careful with that. And definitely you don't want to flush any lines if they have concentrated potassium solution in it. So now we're going to switch gears and talk about a specific clinical example. So meet Jack. It's a 4-month-old male intact German Shepherd dog that is weighing 5 kilograms. We know that Jack was diagnosed with parvo infection and he had potassium of 3 millimoles per liter, which is mild to moderate hypokalemia. So the 3 core questions that we want to answer are, first, do I need to supplement potassium in Jack? Second, what route am I going to use to supplement potassium? And how much potassium I'm going to give to Jack? So in terms of the question number 1, do I need to supplement potassium in Jack? We already have a framework that we can apply to Jack in order to make this call from the previous lesson. So Jack has a combination of moderate hypokalemia, anorexia, and we expect that his disease process, which is parvoviral infection, will probably persist for another 3 to 7 days. So based on the combination of all these factors, we relatively confidently can say, yes, we do want to supplement potassium to Jack. The next question is, do we give it parenterally by IV route or by mouth? So Jack has a dysfunctional GI tract. So he's anorexic, he's vomiting, probably having ileus from all this infection and inflammation there. And he also needs IV fluids regardless. So I think in this scenario, we're definitely going to go with parenteral IV administration of potassium as opposed to oral administration. So now the question is, how much potassium are we going to give to Jack? And that's going to be the topic of this lesson. I'm going to show you 2 methods that I personally use in my clinical practice, but also teach other people how to use them. So method number 1, I call it conventional approach to rate of potassium supplementation. You're actually going to find that this method in majority of the veterinary medicine textbooks, and it is based on this table that was taken from the reference down below here. With this method, the first thing you want to do is to identify how much MEQs of KCl you're going to add to your fluid bag, in this case, either a liter, quarter liter bag, based on the current potassium concentration in your patient. So we know that Jack has potassium of 3. So based on that, we can add 40 MEQs of KCl to 1 liter bag of his IV fluids. And also this table tells us that you do not want to exceed the rate of 12 ml per kg per hour of this final solution once potassium is added. And that's because you're going to exceed the Kmax, which is a scary rate where you may see a lot of issues, which is typically 0.5 MEQ per kg per hour. Now, if we apply this method clinically to Jack, so how are we going to go about that? So step number 1, we want to choose the IV fluid rate for Jack, regardless of his potassium. So how much fluids Jack needs in order to meet all his requirements and fix his dehydration and things like that. So whenever you coming out with your fluid rate, typically you thinking about your maintenance rate, your fluid deficit to correct dehydration, and your ongoing losses. There is a 4th component, which is the correction of hypovolemia. So if the patient presents in shock, it's hypovolemic, it's volume down in the intravascular space, you're going to give a fluid bolus. So we don't account that here because that's going to be very rapid, short-term administration. So now once the patient is euvolemic, it's not in shock, it's not actively dying, we're coming out with a fluid rate, that's what we're going to take into account. The maintenance, the deficit, and ongoing losses. Specifically for 5 kilogram patient that was dehydrated on presentation, is not eating. So first, maintenance. We're going to use this formula 60 ml per kg per day. You may use other formulas, but for the sake of this lesson, we're going to just do the simple math. So our maintenance would be based on that. So we have 5 kilogram dog times 60 ml per kg per day. We're going to get 300 ml per day, and we're going to divide it by 24 hours. So our maintenance rate would be around 12.5 ml per hour. Next step is we calculate the fluid deficit. So we think that Jack was 7 to 8% dehydrated. So in order to correct that over 12 hours, we're going to multiply his 5 kilogram weight times 0.07, which is a 7% dehydration. And we're going to get his total deficit of 350 mils. And we're going to divide by 12 hours. That's the period of time that we want to rehydrate him over. And we're going to get a final rate of 29 mil per hour. And finally, we're going to account for ongoing losses. It's going to be very empirical. We anticipate with his diarrhea, vomiting, he's going to be losing about 20 mil per kg per day. And that will be equal to 100 mil per day with all his losses because he's a very small dog. And if we divide it by 24 hours, it's going to be 4 mil per hour. So now we're going to add everything up and we're going to get the final total fluid rate, which equals to 45 mil per hour. That's how we came up with this rate based on his physical exam findings and our knowledge about this patient. Once we have this fluid rate, we want to make sure it's not exceeding his maximal fluid rate that is allowed. And in this case, 5 times 12, it would be 60 mil per hour. So he's at 45 mil per hour. So we're not exceeding that, which is good. So step number 2, we are going to add 40 MQs of KCl to 1 liter bag of his IV fluids. And again, we're going to do it according to the table. So his potassium is 3. So they recommend adding 40 MQs to a liter with such a low potassium. And that's what we're going to do. So we're going to run his fluids at 45 mil per hour as calculated before with 40 MQs of KCl in it. And we do not want to exceed 12 mil per kg per hour, which is 60 mil per hour in case we're going to change the fluid rate later on. So that was method number 1. Relatively simple, no fancy calculations, just come up with your fluid rate and then add KCl according to the table. So it's a very straightforward approach. It's relatively intuitive. The major con, though, is that it does not tell you the exact absolute amount of KCl in terms of milliequivalents that the patient is getting per hour. And depending on your fluid rate, the actual KCl supplementation may be very different. So imagine that Jack is receiving not 45 mil per hour, but he's receiving just, let's say, 10 mil per hour because he just needs maintenance fluid rate. In this case, his MEQ per kg per hour supplementation would be 0.08 MEQ per kg per hour, and that actually may be insufficient to fix his hypokalemia because this is just a maintenance rate. Now, if for whatever reason we came up with 60 mil per hour instead of 45 mil per hour due to his ongoing losses, he would be getting his Kmax, and his hypokalemia is relatively mild. So by giving him Kmax in the face of hypokalemia of just 3 millimole per liter, you may overdose him, especially if you're not monitoring him closely, you're not doing ECGs, you're not doing his potassium check frequently. So again, my concern with this approach in certain cases is that people don't think about the actual absolute amount of supplementation. And if they're not careful enough and they're not thinking about that and the total fluid rate, that will dramatically change your absolute amount of KCl you're giving to the patient, you may either overdose your patient or underdose. So what is the takeaway here? When you're using this method number 1, or conventional approach, you want to calculate the actual amount of KCl that your patient is receiving in milliequivalents per kg per hour. And I will teach you how to do that when we talk about method number 2. But that will give you an extra piece of information that will tell you about how much actual potassium my patient gets depending on the fluid rate that he's on.